Methods and practical considerations for conducting budget impact analysis for non-pharmaceutical interventions. This presentation is based on our publication in the Applied Health Economics and Health Policy. I thank my co-authors. Here are abbreviations in the presentation. The outline of this presentation. Introduction. A cost-effectiveness analysis, CEA, is used to determine the allocative efficiency, and a budget impact analysis, BIA, is used to estimate the affordability. In an HTA, BIA can be conducted as a standalone analysis or alongside a CEA. Typically, the population of a CEA is a single cohort treated by either the new intervention or standard care. In comparison, the population of BIA includes all patients who are eligible for the new and competing interventions, and the shares of the new and competing interventions may change over time. New pharmaceutical products are often comprehensively reviewed by national HTA agencies, and methodologies for drug BIA have been well discussed. In contrast, although provincial or regional and hospital-based HTA agencies evaluate a variety of health technologies, they most often assess non-pharmaceutical interventions, and methodologies for BIA of non-pharmaceutical interventions have been given less attention in the literature. Roles of CEAs and BIA in national, provincial, and hospital-level HTA. Although BIA is generally associated with funding recommendation, the role of BIA varies depending on the country. For example, HTA agencies in Germany and the United Kingdom do not formally consider BIA findings when making recommendations. In the Netherlands, CEAs and BIA are considered jointly for reimbursement decisions. The United States has no public HTA agencies to make recommendations about coverage or pricing for new drugs, but BIA could be important for determining copayment and coinsurance on a private insurer's formulary. Because pharmaceutical HTAs are generally conducted at the national level, provincial HTA groups in Canada tend to focus on non-pharmaceutical interventions, and BIA plays an important role in reimbursement decisions for these interventions. HTAs may include standalone BIA without CEA in the following situations. High-quality CEAs already exist in the published literature, and the results of these studies are likely to be applicable to the decision at hand. The clinical effectiveness of the new intervention is similar to that of standard care, but the new intervention provides other non-health benefits, such as convenience for patients, such as a home-based treatment or test to replace a hospital-based treatment. Hospitals-based HTAs are conducted on non-pharmaceutical interventions more often than on drug products. Compared with national or provincial HTAs, hospital-level HTAs are typically less comprehensive and completed in a shorter time frame to answer specific questions. In this context, information about the budget impact of a new intervention may be more important for local decision makers than cost effectiveness, and hospital-level HTA may include only a clinical evidence review and BIA. Current BIA guidelines and instructional textbooks mainly address methodologies for evaluating pharmaceutical products, but non-pharmaceutical interventions have unique characteristics. In this section, we outline the features to be considered for the BIA of each intervention type. For surgeries and other procedures, the capacity of a hospital or a healthcare system needs to be understood. The number of patients eligible for a treatment may be greater than the capacity of the hospital or system that provides it. Costing methods and cost components for different treatments are difficult to standardize and are sometimes difficult to compare. For diagnostic test, screening test, or monitoring system, the role of the test in an existing clinical pathway, add-on or replacement, needs to be specified. It may be useful to explore the most optimal allocation of expensive equipment at the provincial or regional level. For therapeutic programs, such as physiotherapy, rehabilitation and cognitive behavioral therapy, patients often need individualized care. These programs include a wide range of variation, such as the therapy components considered, the therapist delivering care, the structure of the service. Analysts can consider standardizing a therapy program in their model and focusing on the core components delivered. Digital health technologies refer to the use of information or communication technologies, such as software and mobile application, in health professions to manage health risks and to promote wellness. A digital health product may be used for screening and monitoring, telehealth, or for treatment, such as computer-aided psychotherapy. Pricing strategies for these products and services are often flexible and complicated. The optimal purchasing plan is often difficult to determine. Literature may not consider health outcomes as the main goals of the studies of digital products. This may lead to challenges including costs related to the health condition. Now, I will present the core section of our article, Methods and Practical Considerations for Conducting BIA for Non-Pharmaceutical Interventions. Hospital funding accounts for a large proportion of public healthcare sector spending in many jurisdictions. We reviewed HTAs that were published between 2015 and 2024 by a provincial HTA agency in Canada. We investigated whether the identified methodological challenges were addressed by existing BIA guidelines. We then focused on challenges that were not adequately addressed in existing guidelines and proposed new methodological approaches and practical considerations for addressing them. Some of our proposed approaches and considerations may also be useful for pharmaceutical interventions. In the slides that follow, we describe the summary and details for each of our proposed methods and considerations. Determining which costs to include. Summary. The costs used in the BIA represent expenditures from a particular perspective of interest, such as a provincial public payer. When considering a shorter time horizon, overhead costs may be set as fixed costs. Depending on the decision context, overhead costs may be excluded. The costs used in BIA also represent expenditures solely from a payer's perspective. When conducting a complementary BIA as part of an HTA, the costs derived from the CEA may need to be adjusted to reflect actual expenditures. Overhead costs such as rent, accounting, and staffing costs can be included as cost parameters in a CEA. When using a shorter time horizon, overhead costs may be set as fixed costs. Similarly, depending on the context and objectives of the analysis, the costs per use of an equipment may also be excluded from the BIA if these are considered fixed costs, because the salaries of staffing and equipment maintenance fees are fixed, rather than volume-dependent costs. We have provided a comparison of the costs relevant to a provincial public payer perspective and the costs relevant to the provider perspective. See the slides. Developing the BIA model with regard to time horizon and adjustment for inflation. Summary. A simple model is generally recommended. In most countries, BIAs use time horizons of less than 5 years. Analysts can use their BIA model to calculate average costs per patient in year 1, year 2, etc. Models need to include both new patients and those who were treated in previous years and who still impact the budget. Adjusting yearly BIA with the predicted inflation rate may provide more accurate financial estimates. BIA may incorporate treatment-related costs and condition-related costs after treatment. If the economic impact of a new intervention extends beyond 1 year, Annual costs for subsequent years should be included in the BIA. If a CEA model has been developed as a part of an HTA, it can be used to estimate annual costs into the future. However, analysts need to investigate whether the CEA model is suitable for the BIA. BIA aims to predict healthcare expenditure changes over future years. In general, the prices of health goods and services increase over time, including health products and the salaries of healthcare professionals. Therefore, adjusting yearly BIA using inflation may provide a more accurate financial prediction. Managing mortality over the time horizon. Summary. Analysts may develop the BIA Markov model to estimate yearly costs per patient over the time horizon for an intervention that has a long-term impact on the budget. Mortality needs to be properly managed in the analysis. When conducting the BIA over a time horizon in which patients have a high risk of death, mortality must be appropriately managed in the BIA model. The BIA model output will generate an average per patient cost each year, which is not adjusted for the per patient costs of those who remain alive in subsequent years. We assumed that a new intervention would impact healthcare costs over a 3-year time horizon. We used two mathematically equivalent approaches to demonstrate how to calculate the budget impact using the BIA model outputs for per patient costs, survival rate, and population size. Approach 1. Sum the product of A. The number of patients who received the intervention in the current year, and in previous years and remain alive the current year, and B. The corresponding average yearly cost per patient for those who remain alive in the current year. Approach 2. Sum the product of A. The number of patients in the initial cohort of each year, and B. The average per patient cost for each year based on the entire cohort, generated by the BIA model output. The underlying concept of Approach 1 is more straightforward, whereas the calculation in Approach 2 is more concise. Analysts may choose either approach to calculate the BIA. Defining the size of the target population. Summary. Estimating the size of the target population using the incidence or prevalence of a disease may overestimate the actual number of patients who will use the new intervention. Instead, analysts should consider the following. Historical volumes of alternative treatments used by patients who are suitable for the new intervention. Whether there is a waiting list of patients receiving these relevant treatments, the policy perspective, such as criteria for eligible patients for coverage, and the role of the new intervention in clinical pathways. For BIA of non-pharmaceutical interventions performed in hospitals. Using historical volumes of relevant interventions to estimate population size may yield a more realistic figure. Historical volumes typically reflect the number of patients who are suitable for the intervention of interest given current reimbursement policies, current clinical practice, and the capacity of the healthcare system. We used an example of endovenous procedures for varicose veins to illustrate the considerations for estimating the size of population. See the slide. Determining uptake of the new intervention. Summary. Healthcare policy. The availability of funding for providers and access for patients primarily determines the uptake of new technology. Other factors that may impact the uptake of a new intervention include the following: recommendations in clinical practice guidelines, labor and infrastructure requirements for implementing the new intervention, the target population size, and patient and clinician preferences. It is difficult to propose a rigorous method for predicting the uptake or the treatment share of the new intervention. The availability of funding for providers and accessibility to healthcare facilities for patients primarily determines the uptake of a new technology. Leveraging the experience of other jurisdictions that have adopted the new intervention may be useful when predicting uptake of a new intervention. This type of information can be obtained from published data or manufacturers. The slide shows some factors that may affect the uptake of the new intervention in details. I will not read it. Interpreting budget impact results. Summary. Adopting a new intervention is a process of reallocating healthcare resources. It may not be financially feasible to realize the savings shown in the BIA. When interpreting a budget impact that indicates a new intervention will lead to cost savings, analysts need to address where the savings are generated from and whether those savings can be reallocated by the healthcare provider or public payer. It is not uncommon for a CEA or BIA to show that the adoption of a new intervention will lead to cost savings. However, the savings shown in an analysis may not be financially feasible to realize. For instance, it is often not straightforward to identify which hospitals or departments would gain the savings and by how much, meaning that the budget holders or beneficiaries of these savings are implicit. In many countries, publicly funded healthcare systems are at full capacity. Under such conditions, savings from reducing nursing time, operating room time, length of hospital stay, etc., would not result in direct financial savings, but may improve efficiency and reduce wait times. Adopting a new intervention is a process of reallocation of healthcare resources. In addition to presenting the total budget impact of a new intervention, BIs may also present costs in main categories. In this way, stakeholders and decision makers can evaluate the trade-offs of the cost components. When interpreting BIA results that show cost savings, it is important to address the following: where the savings are generated from, whether the savings, either in monetary terms or from reduced healthcare resource use, can be reallocated by the healthcare provider or the public payer, and whether additional funding is required to implement the new intervention. Probabilistic sensitivity analysis in BIA. Summary. Similar to probabilistic analysis in a CEA, the method for conducting probabilistic analyses in BIA should capture parameter uncertainty. Some key parameters, such as target population size and treatment share of the new intervention, that are often obtained from sources that are a lower level of evidence, can be treated as assumptions. Analysts may then use fixed values for these parameters and explore the assumptions in scenario analyses. Presently, most BIA guidelines do not recommend probabilistic BIA, and methods of BIA have not been well discussed. In the appendix of our article, we provided some method recommendations. We use a working example to illustrate how to present the probabilistic BIA results. We used the probabilistic model to estimate the annual costs per patient of 3 treatments from 10,000 Monte Carlo simulations. We presented the probabilistic BIA results, mean and 95% credible interval, of the working example in Table A2, which provided the uncertainty intervals of total annual costs in current and new scenarios, and the annual budget impact. The density plot of 3-year additional budget was presented in this figure. The mean value of the total 3-year additional budget was $8.05 million, and the probability of 3-year additional budget less than or equal to $10 million was 0.89. Discussion. CEAs are founded on economic theoretical principles, but in reality, opportunity costs are difficult to quantify objectively or accurately. BIA often includes more practical considerations related to the projected expenditures of implementing a new health technology from the public payer perspective. We have illustrated some methodological approaches and considerations for conducting BIA of a non-pharmaceutical intervention. However, We acknowledge that a fulsome understanding of the context of the analysis is often the most important issue in BIA. I now conclude this article. We propose several methodological approaches and practical considerations for conducting a budget impact analysis for non-pharmaceutical interventions. These methods may improve the accuracy of budget impact analysis in predicting the financial impact of new interventions for the public payer and ensure appropriate budget allocation for decision-making in health system planning. Key messages of this article. The timeline of the milestones of this study. Thank you.